Welcome to this renal cell carcinoma tumor board sponsored by Pfizer and the NCCN through Duke University. My name is Tian Zhang. I'm one of the GU medical oncologists.
Hi, I'm Lisa Ho. I'm a radiologist.
Hi, I'm Wen-Chi Fu, and I'm a pathologist.
Hi, I'm Mike Harrison. I'm a GU medical oncologist.
And I'm Brant Inman, and I'm a urologist.
So we'll start with our first case today. This is a 50-year-old, previously healthy man who initially presented with right flank and rib pain associated with movement. Physical exam revealed normal vital signs, a Karnofsky performance status of 100, and he was a well-appearing man and no acute distress. And otherwise, the physical exam was benign. His labs were significant for a hemoglobin of 12.5, but a normal hematocrit of 39, white blood cell count of 8.7 with neutrophils of 6.2. His platelet count was 212,000. His calcium was high at 12, and his creatinine was normal at 1.2. LDH was normal at 108. This ultimately led to an imaging study. Dr. Ho will discuss our initial imaging for this patient.
The imaging that he first received was an enhanced MRI of the abdomen, and this image shows that there is a large mass in the lower pole of the right kidney, and it looks to invade the renal hilum, but the renal vein was not involved. In addition, he had metastases involving the right lower ribs, and the arrow is pointing to a large soft tissue component to this right 11th rib metastasis.
So that brings us to the first discussion point of this case, and that is the necessity of biopsy. And for that, we will turn to Dr. Inman.
Well, when I look at these images, it's more likely to me to be a renal mass metastasized to the bone than a bone lesion metastasized to the kidney. So in this case, the presumptive diagnosis is one of kidney cancer. The question of whether or not you need a biopsy depends on what you're going to do next. If the patient is going to be a candidate for a nephrectomy, then I wouldn't do a biopsy because the biopsy is not going to change what I do. On the other hand, if it's a patient who's not going to go to nephrectomy, then I would consider a biopsy because we'd need the tissue diagnosis to decide on how best to manage the patient next. So in this particular patient, because I think he would potentially be a candidate for nephrectomy, I probably would not be considering a biopsy.
Great. In terms of prognostic categories, Dr. Harrison will now discuss the Memorial Sloan Kettering Cancer Center criteria as well as the Heng criteria.
Sure. So this is summarized on this slide. There are several prognostic criteria that are used. The first one that's probably the most widely used is the Memorial Sloan Kettering criteria. It consists of 5 criteria. This was published in 1999 by Dr. Motzer et al., and the reference is at the bottom of the slide there. But again, it takes into account 5 clinical factors. So having a low Karnofsky performance status is a risk factor, as is having a high LDH, a low hemoglobin, a high corrected calcium, and having had no prior nephrectomy. All of these are risk factors. Then based upon the number of risk factors, you can group the patients into prognostic categories. So if a patient has 0 risk factors, that corresponds to a favorable risk category. 1 to 2 intermediate risk, and 3 or greater is a poor risk. And these correspond to different survivals. Now that's been updated. The initial Memorial Sloan Kettering criteria were published in the cytokine era. Now that we're firmly in the TKI era where we're using drugs like sunitinib, these criteria have been updated. And the first 4 were retained. So what was added was a short time to diagnosis to therapy of less than 1 year. Thrombophilia was added, neutrophilia was added, and I'm sorry, LDH was actually omitted, the second prognostic factor, because it is not routinely checked. So to summarize, what's called the Heng criteria has 6 risk factors. And again, you can group those patients into risk categories. A patient with favorable risk, as is shown on the slide, has a prognosis of about 3 to 4 years. Our patient has 2 risk factors, so that patient would be expected to have a median survival of about 27 months, whereas poor risk patients have a survival of about 9 months. So in summary, I would say, looking at this patient, he would appear to have a good enough prognosis to think about things like cytoreductive nephrectomy and other local therapies.
That leads us to our second discussion point, which is what is the role of cytoreductive nephrectomy in this case?
Okay, so cytoreductive nephrectomy is when we remove the kidney in the presence of metastatic disease and when we have not removed all of the cancer because presumably there's metastases somewhere else that we haven't removed. And there's two main reasons we might consider cytoreductive nephrectomy. The first is symptoms. So a symptomatic kidney tumor that's bleeding or painful, even if they're a poor risk patient from a cancer standpoint, might be a good candidate for nephrectomy to improve their quality of life for whatever time they have left. And the second reason we might consider it would be to improve their survival. And there's two large randomized trials in the cytokine era that have been conducted. One was a SWOG trial, and the other one was done by the EORTC. And those trials were pooled in a large analysis, and it showed that there was a benefit to doing cytoreductive nephrectomy in combination at that time with interferon versus interferon alone, and it improved survival by about 6 months. We don't have any trials that have been published in the current TKI era, although there are two that have enrolled, the Carmina trial and the Surtime trial, and those are expected to produce results in the next couple of years. But we expect to see probably a similar benefit, although it's really not known. So for me in this patient, the best current data that we have suggests that patients who have their kidneys removed, even in the presence of metastatic disease, live longer and have less local symptoms. And the complication rate of cytoreductive nephrectomy is pretty low. About 25% of patients will have a complication, but of those, really only 5% are grade 3 or higher. Grade 3 or higher are complications you actually need to do something about. So the majority are minor complications. So because there's very few complications, and because there's a potential survival benefit, and because there's a symptomatic benefit, in general, if the patient's in good condition and can tolerate the surgery reasonably well, we would recommend cytoreductive nephrectomy.
Great. So this patient initially underwent a right adrenal sparing nephrectomy and right 10th, 11th, and 12th rib resection. We have the pathology of his initial resection, and Dr. Fu will talk us through that.
So the image that's shown here is from his nephrectomy specimen, and basically everything that you're seeing is tumor. So the tumor morphology of his particular cancer is actually pretty classic. So the cells have abundant, very clear cytoplasm. The nuclei are fairly round, but they're pretty enlarged, and the nucleoli are very prominent. The vasculature is relatively delicate, and there is a fair amount of it. All of this is really good for a diagnosis of clear cell renal cell carcinoma, and this looks fairly high grade in appearance. The majority of the tumor was graded as a Furman grade 3. The next slide shows a higher magnification of some of the more focal areas of the tumor that had very large, very prominent pleomorphic nuclei that have some nucleoli that are actually the same size of the red blood cells that are on the slide as well. And that would be more consistent with the bizarre atypia that you see with a Furman grade 4 case. So he had a very high grade clear cell renal cell carcinoma. Along with the nephrectomy came his chest wall resection, and along with the ribs there was a large soft tissue tumor mass, and this is a representative section from that. If you take a look at the morphology of the tumor cells here, you can see that they look very similar to the initial image that I was showing of his kidney tumor. So morphologically this is consistent with the metastasis from his clear cell renal cell carcinoma.
Thank you. Subsequently, the patient underwent a bone scan, and Dr. Ho will talk to us about that bone scan.
These are frontal and posterior images on the left from his bone scan, and you can see when the arrow is pointing to various sites, one in his right calvarium, his left clavicle, and his left tibia are all sites of abnormal metabolic activity there, indicating that they're most likely to be metastases. The next image is a coned down view of his scalp, his calvarial region, again showing high activity in his right calvarium, consistent with metastatic disease.
So at this point, we considered local therapies for the patient, including metastasectomy as well as external beam radiation. And I'll have Dr. Harrison talk a little bit about which to choose for this patient.
Okay. And, I think the thing to recognize is that, it doesn't have to be one or the other. It could be both. Dr. Inman can maybe talk a little bit about this as well. Metastasectomy is appropriate when there are one or maybe a few lesions that we think we can remove, again, to debulk either all of the tumor or the vast majority of the tumor. Certainly, external beam radiation therapy is appropriate when a lesion can't be removed, for example, in the skull, not practical. So certainly this is a multidisciplinary discussion amongst usually surgery, urology, that is, medical oncology, and potentially radiation oncology. I'll just add that several retrospective series looking at metastasectomy have shown that patients can have good outcomes. I don't know if you have anything to add there, Brent.
Yeah. Well, I would comment that at the outset, this patient had a metastasectomy in his ribs. And the reason that was done was predominantly for symptoms, but also because at the time of initial treatment, it was the only known site of disease. And at this point, 3 months later, we now know that he has more extensive bony disease than we had previously. I think at this point, one of his metastases is in the clavicle, and it is quite symptomatic. So one reason for doing a metastasectomy other than for potential cure would be for symptom control, because it can be very effective for that. And particularly in the clavicle, where it's prone to break, this is an area where we would consider bony resection. The data on metastasectomy for kidney cancer are actually pretty interesting. For patients who have lung-only metastases and that are completely resected, their 5-year survival is almost 50%. For those patients who have disease in the bones, liver, or lymph nodes that are completely resected, it's not quite as good. It's maybe around 30 to 40%, but it's still a lot better than virtually any other treatment at 5 years for metastatic cancer. So for me, if a patient is in good shape, has a good performance status, and that's key, has a limited number of metastases that we feel we can completely resect, then they're generally, and with minimal morbidity, I must say, because if you have to remove, for example, an entire leg, the morbidity of that would be probably outweigh the benefit. So it has to be a procedure that has reasonable morbidity. Then there's a potential benefit to the patient, not only in terms of quality of life, but quantity of life. For those patients in whom we can't have a potential cure, then we really only consider it as a palliative maneuver, and prefer radiation if it's possible. For example, for axial spine metastases, where there's multiple metastases, would prefer radiation in that setting.
Great, thank you. Continuing on with our case, the patient underwent a left medial clavicle wide excision with pathology shown here.
So this is a representative image from his clavicle resection, and the bright pink material that you're seeing sort of in the upper right-hand corner of the screen represents bone. So normal bone marrow is actually hypocellular. You should see hematopoietic elements and fat. And what you're seeing here in the majority of the screen is actually a very hypercellular infiltrate of epithelial cells. And if you sort of think back to the original morphology of his tumor, you can see that they look very similar. So this is consistent morphologically with a metastasis from his known renal cell carcinoma.
Thank you. So 4 months later, the patient underwent a CT of his brain, and he also underwent radiation to his skull to 30 gray in 10 fractions. After he underwent local therapy, he had a CT chest, abdomen, and pelvis 5 months after his initial presentation.
The image on the left shows the lung bases. There is a nodule in the right lower lobe, and the image on your right is a soft tissue window image of his pelvis showing a soft tissue mass originating from his left acetabular, also consistent with metastasis.
So at this point, we come to a role for systemic therapies for the patient, and Dr. Harrison, if you would discuss choosing his first-line systemic therapy at this point.
Sure. So now the patient has had fairly aggressive surgical debulking. The patient has had radiation therapy, and what systemic therapy do we choose? And certainly based on the patient's risk factors, based on the patient's age, we did think about high-dose IL-2. High-dose IL-2, though, has a response rate in the neighborhood of about 15%. So maybe 7% complete responses, only half of which are durable, maybe 8% partial responses. So when we were thinking about how to treat this patient, we were thinking mainly of that lesion in his pelvis and thinking of the size of it, and that if that continued to grow unchecked, he may start to have symptoms. So we needed something with a little bit higher response. And so for that reason, we actually chose sunitinib. Certainly either sunitinib or pazopanib are first-line therapy choices in this setting. So a patient with clear cell metastatic renal cell carcinoma, good or intermediate risk. The difference, again, between drugs like pazopanib and sunitinib and high-dose IL-2 are that the response rate is probably in the neighborhood of 30 to 40%. Now, they don't have the same chance of a long-term response, if you just compare complete responses. So complete responses are probably maybe 1% or non-existent with drugs like sunitinib. So we did talk about this and counsel the patient very extensively about that, and elected to go with the agent with a higher chance of response. We also talked to the patient about anti-resorptive agents. So there are two drugs, zoledronic acid, which is a bisphosphonate, or denosumab, or rank ligand inhibitor, which are reasonable to use in patients with skeletal metastases with renal cell carcinoma. If you look at the trial, which was in all solid tumors, it was a phase 3 trial. Actually, either one, they both included a significant proportion of patients with metastatic renal cell carcinoma, and either one of these drugs did appear to delay or prevent skeletal-related events. So I would say using a drug like either zoledronic acid or denosumab with the systemic therapy is important in this setting.
Do you think there's a role for any of these anti-reabsorption agents? Do they have an anti-neoplastic effect?
That's a good question. That's been investigated, fairly extensively in different randomized phase 3 studies. It's not clear in renal cell carcinoma, at least clinically, that they do have an anti-neoplastic effect. But, I would say they do add to the systemic therapy in terms of preventing important morbidity from the cancer. So they're very important in that regard.
Very good, thank you. That wraps up our first case, and we'll move on to our second case. Our second case today features a 44-year-old man who presented with 18 months of fatigue, arthralgias, night sweats, and weight loss. He had extensive infectious disease and rheumatologic workups, which were all negative, including 2 courses of treatment for tick-borne illnesses. An abdominal ultrasound was performed for fever of unknown origin, which demonstrated a right renal mass measuring 10 by 8 by 10 centimeters. He underwent a CT of the abdomen and pelvis, which confirmed a 10 by 9 centimeter right upper pole renal mass with partial duplication of the collecting system, no lymphadenopathy, and a CT chest was negative for metastatic disease. He had an initial surgery with a right laparoscopic nephrectomy and regional lymph node dissection. Dr. Fu, can you describe his pathology?
Sure. So he had a very high-grade clear cell renal cell carcinoma with 2% sarcomatoid features. So when we say that there are sarcomatoid features in a carcinoma, that typically means we're seeing morphology that is very atypical, high-grade in appearance, often spindled in appearance, and that is generally associated with a poorer prognosis. And so even if it's very focal, we would still report a Furman grade 4.
Great, thank you. 1 year later, he was undergoing staging CT when he had a chest, abdomen, and pelvis CT performed. This showed in the medial edge of the right middle lobe of the lung, he had a nodule that was previously measuring 0.8 by 0.9 centimeters 3 months prior, and that had increased in size to 1.3 by 1.4 centimeters. There were no other definite evidence of metastases. So for this patient, we were hoping to discuss additional staging as well as role for biopsies or metastacectomies at this point.
I'd like to make a comment first about the history. The first question that pops up, I think, for many patients is, at the time of his first surgery, when he had stage 2 high-grade sarcomatoid renal cell carcinoma, was there a role at that point for adjuvant therapy? Should he have received systemic therapy after nephrectomy? And this is a common question that patients ask when I tell them they're at a little bit increased risk of recurrence because of the sarcomatoid features in their tumor. They ask if there's anything that we can give to prevent that. And I was wondering, Mike, if you could comment on that. What do you think?
Sure. No, this is a great question, and this, again, is a question that's commonly asked by patients. Given the activity of drugs like Sutent, sorafenib, et cetera, in the metastatic setting, it could be reasonably wondered maybe we should try to treat high-risk patients to try to reduce the risk of recurrence or at least delay recurrence. So as far as the evidence that is known right now, recently the ASSURE study, which was looking at adjuvant sunitinib or sorafenib, did not show a benefit to adjuvant treatment for high-risk patients with localized renal cell carcinoma. There are multiple other studies, STRAC, Everest, using other agents, including axitinib, everolimus, etc., that have accrued and are waiting to read out. But at least the first results that we have do not support adjuvant therapy at this point, unfortunately, for patients.
Yeah, I think that's exactly what I would tell the patient too. And the other thing is, patients with sarcomatoid tumors in general are not generally very responsive to tyrosine kinase inhibition or mTOR inhibitors that we know of.
Right.
So, there's maybe those two reasons. As for this patient's lung lesion, it's small, it's unifocal. For me, this at this size, 1.4 centimeters, it might be very difficult to biopsy. Generally, lesions at a centimeter in size can be tricky, but I would consider this potentially for a resection. This is a tumor on the imaging that is very peripheral in the lung, and would look to me to be amenable to thoracoscopic wedge resection. So my first thought would be, well, it's a unifocal site of disease. Maybe it can be resected, but before doing that, I'd want to make sure that there was no other disease elsewhere. And for me, that would include a bone scan to look for disease in the bone. And if he hadn't had a CT of the abdomen and pelvis, but I think he did, I would check that. But if the CT of the abdomen and pelvis was fine, the bone scan was clear, and with a solitary lung lesion, I personally wouldn't scan the brain. I would generally do that when the burden of disease above the diaphragm is high. So multiple or lung metastases is when I would, or multiple lung and bone metastases, that's when I would consider checking his head.
Yeah, no, I agree. And I think certainly in this patient, a metastacectomy would make sense. I think the thing to realize with systemic therapy is that it has real side effects. The progression-free survival, depending on what drug you use, sunitinib, pazopanib might be appropriate in this patient, would be about 8 to 9 months. But during that time, the patient is having side effects, fatigue, hypertension, et cetera, et cetera. Whereas if you could treat the patient with local therapy, potentially do a wedge resection or some other way pluck out this nodule, even if all you did is delay the time to systemic therapy, that would be a benefit to the patient.
Yeah, and for thoracoscopic wedge resections, the recovery period is remarkably quick. Patients leave the hospital usually within a couple of days, and usually within six weeks are pretty much back to baseline, assuming that there's no complications.
So the patient did undergo a right thoracoscopic wedge resection when the pathology showed a 1.3 by 1.2 by 1 centimeter clear cell carcinoma with negative margins. Dr. Fu, do you want to comment on his immunohistochemistry staining?
Sure. So the immunohistochemical findings on the lung nodule showed positive staining for RCC and CD10, as well as some patchy staining for vimentin and anti-cytokeratins, and those are all very consistent with a diagnosis of metastatic clear cell renal cell carcinoma. a TTF1 immunostain was negative, and that was done to make sure that it wasn't a pulmonary adenocarcinoma, and those tend to be positive for TTF1, whereas a renal cell carcinoma would be negative, as this case was.
I think this case demonstrates really the role of metastasectomy in renal cell carcinoma. It also demonstrates the patients that tend to benefit. So metastasectomies tend to work best in people who have lung-only disease versus disease in other sites, although it can be beneficial in those other sites. It tends to benefit patients who have asynchronous recurrence of disease rather than synchronous disease. And it tends to benefit patients who have a low number of metastases, 1 or 2 versus 3 or more. So this patient basically had several risk factors that would suggest a good outcome with metastasectomy. Solitary, lung-only disease.
Thanks very much for that commentary. And the patient has remained without evidence of disease now 4 years after metastasectomy, so he met all those criteria. That concludes this case. Thank you for joining us for this session of the Renal Cell Carcinoma Tumor Board.